So here we have a patient of CKD with volume overload. This is the echocardiographic findings. Here we can see the tricuspid regurgitation. Here we can see the artifacts. There are the B lines, more than 3 B lines. This is we are evaluating the RV systolic function, that is the TAPSE, which looks normal. RARV size is also even normal. Here we can see the more than 3 B lines which are suggestive of volume overload. We can see the generalized LV hypokinesia as well as the mitral regurgitation, and the left ventricular hypertrophy is also there. So these all are the features of volume overload. This was a young female of diagnosed case of stage 5 CKD. Here is the IVC, which is dilated and having less than 50% collapsibility with the respiration. There is presence of pericardial effusion minimal, and there is a gross right sided as well as left bilateral pleural effusion is also there. All these are the features of the volume overload in the patient. We can see that RV systolic function is normal, but there is presence of the generalized LV hypokinesia and moderate LV systolic dysfunction is there. This is again the B lines, more than 3, and the pleural effusion, which all collectively suggest the volume overload. So this was a patient of CKD which was advised for the dialysis but not on regular maintenance hemodialysis. As a result, she landed into the gross pulmonary edema, fluid overload, even requiring the non-invasive ventilatory support. Before I just shown the X-ray, after one 3-hour dialysis, we removed the around 3 liter UF, and then the opacities in the X-rays that were reduced. So these findings in the video, they are important, as whenever any patient comes with sudden onset dyspnea, especially we describe the patient of CKD with volume overload, but in general when we suspect the pulmonary edema or volume overload clinically, apart from the routine clinical examination findings, the echocardiographic features and radiologic findings, they give us the objective evidence, such as in the X-ray we had seen the bilateral symmetrical opacities as a result of volume overload, and after some amount of the fluid was removed, as in our case we removed the 3 liter of the fluid, the opacities in the upper zone, they were decreased. Similarly, in the echocardiography, we had seen that patient had CKD related cardiomyopathy, and as a result of that she had a generalized LV hypokinesia and moderate LV dysfunction, and as a result of volume overload she had mitral regurgitation, MR, TR was there, IVC was dilated, she had pleural and pericardial effusion and more than 3 B lines in all the lung fields. So collectively these all were the features of patient with the CKD related cardiomyopathy and volume overload. Thank you.